I'd like to invite Susan Desmond-Hellmann and Brook Byers to join us for the panel discussion on the future of cancer research. The way this is going to work is if you have any questions, burning questions you'd like to ask any one of the panel, I believe you have cards in your invitations. Is that true? So please jot down the questions and then pass them on to one of the will field the questions to the panel. Okay. So first of all, I want to introduce the panelists. Susan Desmond-Hellmann is our Chancellor Designate. I did not know she would be my new boss when we invited her to join the panel. She served as President of Product. She's, I gather, board certified in internal medicine and in medical oncology and completed her clinical training at UCSF. Sue has brought some of the most successful and innovative oncology drugs to market, some of the biggest, most successful drugs. Rituxan, the first drug that used monoclonal antibodies and is now, I believe, standard of care for treating B-cell lymphoma. Herceptin, which opened the doorway to personalized medicine by targeting the HER2 gene in specific subsets of breast cancer. And Avastin, oh yeah, Avastin, probably the most successful cancer drug. Top 50 most powerful women in business, amongst many other awards. So we look forward to hearing her comments, but I just want to say congratulations on that set of achievements. Brook Byers is a partner at Kleiner Perkins, Caulfield & Byers, and has been a venture capital investor, entrepreneur, and company builder since 1972. Brook has deep healthcare and biotech expertise, having formed the first of 4 life sciences companies. Brook and his firm have helped scientists and entrepreneurs build over 100 life sciences companies. Quite amazing. I personally had the pleasure of working with Brook when he was on the board of directors of a little company called Onyx, which I co-founded, and he helped launch. Possibly the highlight of your career, Brook. Is that possibly true? He personally helped found and build companies that pioneered monoclonal antibodies, including Rituxan, in fact, as well as techniques in early gene sequencing, novel drug therapeutics, combinatorial chemistry, the Oncotype DX breast and colon cancer assay tests. Brook has been an active advisor, volunteer, supporter, and foundation member at UCSF for over 2 decades. In fact, in 2007, he was awarded the UCSF Medal. He is a fellow of the American Academy of Arts and Sciences, and in 2009, he received the Lifetime Achievement Award from the National Venture Capital Association. And he's also, I would say, a cool dude, if I may say so. So please welcome, please welcome Brook. And I think the discussion will possibly break down into 2 major areas. One, therapeutic implications, that is sort of personalized medicine. That is the idea that by understanding the genes that cause a particular cancer, one can match a particular therapeutic to treat that cancer. This is already having a major impact on cancer treatment, and Sue's development of Herceptin is probably the best example of that. So we'll hear more about that and the implications of the therapeutic approach based on understanding the genomes of cancer. Sort of clear cut and maybe even slightly worrying is the possibility that Craig referred to, that in a few years' time, any one of you can have your whole genome sequenced for a few bucks. And then based on that sequence, you'll be seen to be at risk for certain types of disease, including cancer. Now that concept is already here, and I'm sure you're all familiar with some of the implications of this. But it certainly has sort of worrying connotations and raises all kinds of issues as to how we're going to deal with that kind of information and how we're going to process it and disseminate it to people in the community about it. So I think I'd like to break the discussion into, first of all, a discussion of the sort of personalized medicine therapy benefits of understanding cancer genomes and matching those to drugs that work on that subset, and then we can get on to talk about how we're going to deal with this tide of information which is coming down based on the fantastic advances in genome sequencing that Craig and others have pioneered. So if that works for you, okay, I'm sure it'll get muddled up and crossed over, and let's just very kindly, I actually flew back from the big clinical oncology meeting in Orlando, where every year the ASCO meeting, all the latest breakthroughs and advances in oncology are presented. It's a huge event where investors and patients and advocates and everybody needs to see how we're doing in terms of developing new therapies. Sue, I presume, presented there and participated, but came back early to be in this session. I'd like to start off the discussion possibly by referring to a few highlights from ASCO and where you see
maybe I could just tell us a little bit of a story about Herceptin to start off the panel, because it helps me put into context what I came away from the clinical oncology meetings in Orlando with. My story with Herceptin actually goes back to when I was a community oncologist. So I was, as my parents say, a real doctor at one point in my life. And because of the community I was practicing in Lexington, Kentucky, where my husband came from, I was the only female. And that was in 1991 and 1992. And I remember like it was yesterday, one of the least favorite discussions that I had. And the discussion would go like this. It would be, Mrs. Jones, you have breast cancer. And in fact, now because of advances in testing, we've been able to test your breast cancer. And I know that your breast cancer overexpresses or has too much of this certain gene called HER2, a receptor that's expressed too that in the early 90s. And why it was a bad conversation is my outcome was I would say, let's worry more. And the reason I would worry more is it was already clear in the early 90s that women who had this form of breast cancer, about a quarter of women with all breast cancer, from the time of their diagnosis, lived on average 3 years. The 75% of women who didn't have this marker, HER2, on average lived 7 years. But I had nothing to do but worry more. Maybe in 1995 when I came to Genentech, what I liked best conceptually about Herceptin, because we didn't know yet about whether or not it would work, what I liked best wasn't that it was personalized or might start a field. I didn't know that then. But the concept that you could take what seemed to me this wicked advantage that the cancer had could be turned into potentially a disadvantage, an Achilles heel, because we could take that very overexpression, the fact that genetically there was too much of to target the cell, try and kill the tumor cell, and maybe help patients. And in 1998, Herceptin was approved, the first time we have had a cancer drug approved only for those patients who had too much of this HER2. And now a doctor could say to the patient, I'm more worried, but we have something for you that can help you live longer, even if your cancer spread. And so Herceptin was the first product that not only were we able to tell a quarter of women, this is something, but just as importantly, 75% of women who wouldn't be helped, their physicians could say to them, you shouldn't have this medicine. Like all medicine has side effects. We won't expose you to a treatment that won't help you at all because you don't have this target that Herceptin was made for. So that really changed everything about how we thought we should even have conversations with patients. So that happened in 1998, and I thought and said many times, wrong. One of the things that I predicted, and that's one of the exciting things that just happened at ASCO, I predicted that we would stop talking about cancer by talking about the anatomy. I mean, it is a little odd that we talk about cancer still by where it started. We still talk about breast cancer. We don't talk about HER2 expressing cancer, which is what I predicted. So at ASCO, just 2 days ago, a study was presented in stomach cancer, gastric cancer, in about normality, HER2 overexpression is found. And in fact, when patients with stomach cancer were treated with Herceptin, there was a 25% increase in survival compared to no Herceptin. So this is now a second cancer. So Herceptin, I would predict, will no longer be thought of as just a breast cancer drug. It's a HER2 positive drug. And so the demonstration that in fact you could test for HER2 in stomach cancer and extend survival only in those patients with As importantly, the stomach cancers that don't have HER2 shouldn't be treated with Herceptin. The other paper I saw at ASCO that I thought was really impressive and comes from some work done at UCSF was an inhibitor called a PARP inhibitor. And the details of the PARP inhibitor are less important than what it meant for patients who could be treated. So in breast cancer, again, there's about 15% of patients who have what we call triple negative breast cancer. They don't have HER2, so we can't use Herceptin. So they're actually defined by what we can't do with personalized medicine, triple negative. And these patients have one of the toughest forms of breast cancer to treat because we haven't had new medicines for them for quite some time. But they do seem to have an excess of DNA repair. When we try and hit their tumor cell with classic therapy that interferes with DNA, they repair it. They come right back. And so the PARP inhibitor prevents their cells from doing that. So again, in a targeted therapy for only survival was already demonstrated by turning off this let's fix the cancer cell mechanism. So what I came away from ASCO thinking is we might not have something for all patients with cancer, but it seems to me we're systematically now going back to the cancers, looking at the genetics of that cancer, and able to say if something's turned up, let's turn it down or turn it off. And those examples in stomach cancer and in breast cancer taught me that maybe 1990.
Just anecdotally, the PARP inhibitor was invented actually by a chemist at UCSF called Ernst Kuhn, some of you may know. Is he in the audience? Okay, good, then I'll proceed. I first came across Ernst Kuhn when I was a young scientist about 100 years ago at CETUS. And I was told there was a chemist working in UCSF who had some great compounds. So I came over to UCSF and I was led to his lab, which was then in like a shed somewhere in the woods up behind chemist. And he had some interesting compounds, but I lost touch with him. And then I met up with him again more recently, and we gave him a bit of lab space down at Mount Zion, where he'd been working on inhibitors against this class of enzymes in a very eccentric way.
They look very good. Yeah.
One interesting feature about this set of targets, though, is that they seem to be initially at least effective on tumors which were defective in the BACR1 gene. I'm sure you're all familiar with the idea that and currently, their options right now are pretty drastic, surgical options to prevent them getting disease. But it turns out that defect in a DNA repair enzyme makes them susceptible to this kind of therapy. So it may be that, that there's hope for that set of patients if this drug really does sort of get through.
Well, the data that was presented in breast cancer included patients with this, with the BRCA1 and 2 deficiency, and there was also ovarian cancer data in the same.
That's really amazing. Because prior to that, I was going to sort of make the pitch that it's really awful to know you have a high risk of a disease if there's nothing you can do about it. But now there may be hope for that set of individuals. We'll see. Speaking of breast cancer, I don't know if it's appropriate if Joe is ready to stand up to cancer, and because the co-winner of the award that I mentioned earlier on was Dennis Slayman, who's one of the people that first pioneered the idea of targeting HER2/neu and one of the developers of Herceptin at UCLA in the early stages of development. So Joe and Desmond-Hellmann are going to achieve. Go. You can just shout, I think.
Perfect.
Okay. Okay, thank you. Thank you. Thanks. So apparently Joe couldn't be heard on the webcast, but his idea is to use more refined genetic analysis to subdivide which maybe one of you guys could feel, and that is as cancer becomes segregated into smaller and smaller niches where you have drugs that are more closely matched to smaller and smaller markets, does that affect the appetite for big pharma, or any pharma actually, to develop drugs if we're chasing smaller and smaller indications? So I think in the old days, when we started Onyx, we sort of dismissed any targets which were less than $1 billion market potential as being uninteresting for big pharma. That was probably completely wrong, but, but it is a trend when you say that. Of development and marketing. Is that true?
Well, yeah, but it changes them in the same direction. So I did some homework this morning on the number of FDA-approved cancer drugs that are targeted right now, and there are 18. There are another 400 drugs that are in different stages of development for cancer by 1,000 companies, so-called biotech pharmaceutical companies around the world. So all of them are and what they all can do is, as they go along, develop what we call biomarkers, and that's one of the subsets of the conversation today. We're still in early days on biomarkers. They can be gene targets or protein targets or part of disease pathways. Frank was a pioneer in looking at disease pathways, so UCSF is so fortunate to have a head of their comprehensive cancer center who has this expertise. But as the understanding of segmentation of patients and different types of cancer by how developing that drug and doing the clinical trials will come down, so it's still economic to develop it for what might be a smaller market. While I'm talking about Frank, I also want to say that, put some perspective on this. I'm the one person up here who's not a scientist or doctor, and I see this world somewhat from the outside, like many of you. And the perspective I want to give today on this building and where it sits is that UCSF is a remarkable institution. I think maybe the best in the world for biology, biochemistry, molecular biology, sequencing, genetics, medicinal chemistry, biostatistics, informatics, all these things that come together and are integrated that give us these solutions. And all pioneered as well by Mike Bishop. To talk a little bit about Sue and where our worlds connect, we're really soulmates because I was observing what she was doing at Genentech with Herceptin. So I got involved with a project that Frank asked me to talk about, and that was to take all of these concepts and ideas. Really, it's the power of an idea, a new idea, and then the power of all the information that Craig showed could be generated about the human genome and the genes, and understanding then candidate genes and looking at disease. And so I took a different approach, which is instead of looking at drugs, look at diagnostics. And how can we transform diagnostics to change the way we're doing medicine. Diagnostics are pretty crude right now. It's pretty early days. And so what I did is I started a process where I'd look at the doctor and the patient sitting in an examination room trying to make a very difficult decision. Let's say it's a woman with breast cancer. Should she have chemo or not? The same can be applied to a colon cancer patient, a prostate cancer patient. What should this person decide? They're probably going to have the surgery, but then what? And so we decided to then start with a patient. Could it be gene expression? In some diseases, it's proteins, protein markers. Then once we choose that and the candidate markers there, then we work backwards to what tools will show us that. And it just turns out about the time Craig was finishing his work, automated RT-PCR with TACMan came out. And then better bioinformatics and limb systems and statistical methods. And so we started with a large number of genes, candidate genes, and would put them on gene chips. And this is maintaining good sample sets. UCSF has a great system for doing that as well. And then get down to a constrained set of genes, in this case of Oncotype DX, 21 genes, then run a large number of samples. That diagnostic has now been run in 13 different validated clinical trials on 4,000 breast cancer patients, so high scientific rigor, and came up with a test that would predict the chance of recurrence and chemo responsiveness. Breast cancer situation, it was a tumor with a certain profile for that patient that determined whether or not that patient should get chemo. And what we found is that 90% of women were getting chemo and less than 10% were benefiting. That means most of them didn't need to have it. This was an amazing finding. And now we're applying this technique to colon cancer, and we just released on Saturday at ASCO. In patients believed to be at risk for thyroid cancer. So they go to a doctor, and in the United States, each year there are 400,000 fine needle aspirate biopsies taken of people who are concerned about having thyroid cancer. From that, the diagnostics are not perfect, so 100,000 of them have surgery. And once they have the surgery, then they can look for cancer. 80% is broken. And so I think that one of the other things I want to have you take away as today is there's a huge amount of research going on that side as well, and then it comes together in the ways Sue described.
Mm-hmm. I thought diagnostics was considered a bad business by the venture capital community. Does something change?
Well, it's changing.
The margins are so small.
It's changing somewhat slowly. There are always impediments to trying to translate this from research them worldwide. The FDA is really not ready yet for these advanced diagnostics, so there's work to be done on understanding how to regulate all of these. The business community, the commercial community, the biotech community still have not settled out what is clinical validation and the rigor that needs to be done. Some companies are doing it, not all. And then on the other side, reimbursement is these kinds of diagnostics take tens of millions of dollars to develop, and they need to be priced for value. They can save the healthcare system money. So that's coming around as well, and the need to improve how these are reimbursed. There's an old system, CPT codes. Those of you who are doctors, you know these ICD-9 codes and CPT codes. This is an antiquated system that was written decades ago before these two revolutionized medicine.
whether or not it's viable to study subsets of tumor types or small tumor types. What I think is not to be missed is how small a sample size, how small a clinical trial you can do with a targeted or personalized therapy. The PARP inhibitor study I talked about with a significant improvement in survival, so very rigorous, very well done, was 112 patients.
Yeah,
that study,
amazing.
if you made a little bit of a difference with process and your ability to show a big difference, which you really have to today, is enhanced. So I went to one of the presentations I went to at ASCO was a Pfizer molecule, biggest drug company in the world. And it targeted ALK in lung cancer, 5% of lung cancer patients.
Wow.
And so I think this party line that pharma won't go after targeted therapy or small subsets of patients, these are very we should challenge ourselves about how efficient or inefficient the clinical trials process is and work on that end of things.
Yeah, I agree.
Yeah.
Yeah. In fact, the model has to change.
Yeah, it can't stay the same.
A model of giving the same drug to a large number of people when it now science shows only works in a small population, and that being the economic basis of advancing company profits is just foolhardy.
Right.
And the more science progresses, the more silly that it's not profitable, it will go away. I think there'll be, as we heard, new basis of developing that profitability on the very specificity of the predictions.
It seems to be the major sort of financial anxiety in a lot of biotech companies I'm familiar with is actually the cost of getting approval rather than what happens in the market, because that's so expensive and all the risk is in the approval process, not in the post-marketing, right?
Yeah.
So anything which gets you into the market.
But if the tests are done using the specific criteria of genetic,
another way to think about it is that there are two ways to approach drug discovery and development, but they're converging. One is you screen drugs against human variation, which is what Craig was talking about, which includes epigenetic changes between people, or you screen patients against the drug to eliminate non-responders beforehand.
Yeah. Yeah, and speaking of which was another sort of personalized medicine story which is close to my heart, and that is that as another in KRAS, which is the gene that I've been trying to find therapies against for about 100 years without much success. So the Genentech studies show that in lung cancer, not only do patients fail to respond if they have a mutation in KRAS, they may actually do worse. I'm not sure if that still holds up, but they certainly don't respond. So those patients should not be treated with these drugs. And in Europe, I think that it's actually on the label, do not give this drug to a patient with KRAS. But in the US, I gather the FDA hasn't quite come there yet. Is that true?
Well actually, I learned more about that at ASCO because KRAS, not like HER2 to say who should get the medicine, but who shouldn't get the medicine.
Right, yeah.
And in fact, Amgen's product called Vectibix is a colon cancer drug. And they showed very clearly that the colon cancer patients who had this mutant KRAS did worse. And the European regulators, for the first time ever, put this negative predictor in the Vectibix package insert for colon cancer. And so at this meeting at ASCO, both for Erbitux, Implone, and Bristol Myers product, the studies aren't consistent, which is a little disappointing. Interestingly, they're consistent in colon cancer. Maybe you can explain this because I was left scratching my head. Why KRAS would be a negative predictor for blocking HER1 or EGFR in the case of colon cancer, but not in the case of lung cancer. And it may just be because the benefits of the inhibitors are modest in lung cancer as compared to colon cancer, and you just don't see the difference by KRAS. But it makes biologic sense, first of all.
Totally, yeah, right.
It's consistent with the worse. So this sense that you not only pick the therapy by the marker, but you pick which therapies you shouldn't get, was really novel and
Right.
a big change in how we looked at things.
Yeah. But if that becomes common practice, then before anybody gets treated, they're going to have some genomic test to eliminate, to make sure that they're in the right category. And then so the question then is, what are the technological innovations that are going to make it possible to get to KRAS mutation detection in a patient without any invasive biopsy? I'm wondering if Kay's got any really nail down these issues.
Well, because we've had such limited sets of information, we take the target or the candidate gene approach is what's been going on. If we could sequence 10,000 genomes and we had all the clinical and phenotypic information associated with that. So think of each of you had to write down all the information about your life, all the chemical information, your thought processes, how your brain works, your base against the genetic code, we'll be able to work out which components are really genetic, which ones are environmental, which ones can associate with wellness or disease. And the trouble with candidate gene approaches or candidate target approaches, we have 23,000 genes in the human genome, 100 trillion cells, different types of expression in different cells. And for example, with the BRCA1 test, a lot of women have, they're positive for that test, but they don't. You look there because that's where the light is. But in fact, as we start to understand our biology on a more complete basis, we'll find that there be genes and proteins that are protective, those that make us more susceptible for other genetic changes. So we have a very limited subset. I think that's the biggest thing that's going to change over the next few decades. We're going to be swamped with information. The challenge is converting that information into knowledge and understanding. But
Yeah.
Right. No, and I think that is, I really like what Brook said about the ability to collaborate and having the basic scientists and the clinicians working together. A very practical challenge with this is that you have to have tumor tissue today. So that is a huge impediment because diagnostics in the clinic have gone away from taking a large biopsy. That's hard on a patient.
Right.
So in lung cancer, we don't take a big needle aspiration, a tiny amount of material. And then when we want to go back and do a lot of genomic testing on that, we have too little tissue.
Yeah.
So that's when the clinicians turn to the basic scientists and plead for help, that we can't do proper diagnostics on a patient. So the collaboration of being able to use some practical clinical understanding of these diseases and the impediments to getting better diagnostics and working together in a basic way to solve those problems. I think that's more important.
About his wish, and it's amazing what's happened in the 10 years since you did that. But there are several companies working on these advanced sequencing machines. And believe me, anybody working on an advanced sequencing machine, when they get the prototype working, the first person they take it to is Craig. So he gets to see everything. And within, I would say so, the $1,000 complete years away.
maybe 18 months for
Maybe
a couple
18
of
months.
these. Yeah.
Okay. And doing it single molecule sequencing and could do it on a single cell. Right. So what I don't think to date there's ever been sequenced, for example, a cancer stem cell. Is that right?
Not a cancer stem cell, but there have now been a couple of cancer genome projects looking at the entire tumor. And as you know, the number of genetic changes sort of stem cells, and our team has perfected the ability. We can even do the genome on a single bacterial cell now. We can amplify a single molecule of DNA. So I think doing individual stem cells, cancer stem cells, will be, I think, really critical for the future. And that's hopefully only a few years away on the scale of the human genome.
Now we can settle that question, cancer stem cells, the root cause in there or not, and then you do adjacent tissues, and then so my groups diagnostic, then maybe we can get even better predictive value out of the diagnostic and then help the clinician.
Well, we've been sort of working on the assumption that one of our dreams for the future, which would be useful to do, would be to have all of our patients who come on clinical trials or even actually come in with, get diagnosed with cancer at the center, have them sequenced completely, or at least as much as we can afford, or have them genotyped in different ways so that we can develop databases that track get that whole process started. And actually, I'd just like to take the liberty of calling on Eric Small, who's head of our Investigational Therapeutics Initiative, and also flew back from ASCO to be here today. Eric is trying to put together a sort of a lean and mean clinical trials operation, which would include eventually that kind of comprehensive analysis of all the patients that come into the center. Anne is shouting at you. You have to come.
Can you use the mic?
Use the microphone.
Just leave.
Sorry to wake you up.
You'll pay for this.
This is a phenomenal panel discussion because it really gets to the heart of what we're trying to do at UCSF. And it's just we've all alluded to those bridges. I think the bridges between cancer genetics and patient genetics. How do you personalize a drug? I think a really important bridge is a bridge between the Helen Diller family research building and our outstanding clinical research programs that are at Parnassus and Mount Zion, that linkage. And one of those linkages that I think all three of you alluded to is biomarkers, how you can use this basic biologic information to inform clinical decisions. And our goal, as Frank alluded to, is to do that with every new cancer patient. Several outstanding programs, two of the programs that are in this building and the neuro-oncology and urology programs, but elsewhere. And our goal is to extend this throughout all of the cancer center in an efficient, timely fashion. So I'm only repeating the words of these incredible people here. So thank you.
Thanks, Eric. So I think one limiting technology which will we're sort of running out of ways of actually targeting them. You know, unless they're a kinase or a surface protein or certain enzymes, we can't really do much about knocking them down or regulating them. And my sense is that in the sort of, we've got plenty to do for the next 5 years, but that in the longer term time frame, there's going to be a bottleneck in drug development technology. It's already so slow relative to our advances in DNA sequencing that we'll have a ton of knowledge about pathways and targets, but nothing we or across the horizon, which might give one reason to be optimistic that something will change radically enough for us to hit all the dozens of targets which aren't kinases and enzymes. And I'll call on Brook first because his job is to see the future and make it happen by investment.
I'm glad he called on you first.
No,
I'll give you time to think of an answer.
First thing I do is I call Frank, Mike Bishop, and Sue Hellman. So, mention an area that I'm very excited about now is epigenetics. Thanks to Craig and colleagues, they sequenced the human genome, and we got that blueprint, or that's probably the wrong word, but what's your favorite word for the whole?
A starting point.
Research project.
He's humble. Okay, so I was thinking today of an analogy on this, and is like whole sequence of the human genome is, think of it like sheet music. So we all have the same set of sheet music, and we're all going to play the guitar together. But we will have variation among us as to how we hold the frets and how tightly we push the strings and how we strum and the rate at which we strum. And that is the differences among us and the variation that Craig was talking about how our genome genetics, which explains a lot of the variation. And I think this is a very exciting field, and it has to do with not the expressions of genes, but proteins called histones. I think those will be new targets that will give us new information on cancer.
Okay.
I've not heard that metaphor before.
But will you use it again?
No.
I wanted to be in his next book.
Well, there's one technology actually as a therapeutic modality, which I think seems to me to be, although it's not there yet, the only thing I can see on the horizon which has the promise of being able to deal with all the complexity that we've been talking about, because it can knock down genes, any gene without preference for the protein product.
Well, in fact, they're a great example of how fast our ignorance is changing, or perhaps how slow it is. So everything that was not a part of the genome that coded for a protein, some of our brilliant colleagues labeled that as junk DNA. Clarification, he says, junk is what you store in your attic, rubbish is what you throw out. And it's a good thing we didn't throw it out, because as we look closer and closer at this junk DNA, that's in fact where all these regulatory RNAs are being found, that do control gene expression. We're also finding that methylation of DNA is important, as now we can measure that easier in the genome. It explains some of these strange phenomena that people see where even though they inherit DNA from other plays an extraordinary influence, this imprinting that's been going on that is just being understood. So there's a lot of changes that take place in our genetic code that as we start to measure them and we can understand things that regulate gene expression, those are new avenues for coming up with ways to interfere with it. I think the wonderful work that you did with HER2 and this new approach of using therapeutic antibodies shortens the time course tremendously. It depends. New knowledge can be much faster, but our biology is pretty complex. The fortunate thing is we're now starting to understand that complexity. One thing that it's important to take into account is in addition to our 23,000 genes, we have about 10 million other genes associated with us. People don't like to think about it, and it doesn't matter how hard even surgeons scrub going into surgery, you can't get rid of the roughly 3,000 or 4,000 bacteria. They play an important role in physiology. Each of you have about 500 chemicals right now circulating in your bloodstream. A few more in California than other places, perhaps.
Who have you been talking to?
Only about 60.
Frank's worried about the half-life.
60% of those are from our own human metabolism. About 30% are from all the different species we consume in our meals. 10% if these affect your mental processes. We don't know if they prevent diseases, whether they increase the rate of cancer. So we're starting to understand human complexity in our physiology, probably for the first time ever, seeing the extent of it. That gives me great hope, because it means for the first chance ever we have a chance to truly understand and put it all in the context to come up with new approaches for intervening with it. In the past, we've been doing it in a completely ignorant fashion.
Damn, do we have
worried about the technical approaches. I like siRNA like you and Joe do as well, but if I think about the next 10 to 15 years, both small molecules, antibodies, armed antibodies, maybe some new immunologic approaches, I'm less worried about the technical approaches and more worried about the complexity. The multi-gene driven cancers still elude us, and unfortunately those tend to be the most important killers.
Right.
Those are the hard cancers to treat. Have a cancer that seems to be driven, if not singularly, then mostly by one target. We can sort that out, and we have tools for that. So the tools aren't letting us down. The complexity is overwhelming.
Right.
That's what I struggle with more than the approach.
Yeah, and those things can be addressed by the research community here, really, in a way to understand how tumors adapt to therapy and rewire themselves and sort of get on with it.
Right, how they always outdo us. I've always thought that if we could partner with our diagnostic colleagues and say, okay, if day one, here's the genes that are driving your cancer, and then you just stay ahead of it. And you do like you would with an antihypertensive. When your hypertension is no longer being controlled, you switch to medicine number 2 and medicine 3. But the complexity of what goes up and what goes down and our ability to measure that and act on that is overwhelming.
Right. And the other element which people often toss in that company doesn't have both drugs in their arsenal, it's very hard to get the combination tested.
Okay.
But you probably saw just yesterday or the day before it was announced that Merck and AstraZeneca are going to do a combined study where each has a drug against one arm of a pathway which are expected to work together in cancer. Did that shock you as much as it shocked me? It seemed like it's so logical, but that's something which people have argued for a long time will never happen.
Well,
or
the best
too
part of
complicated.
the story was they figured it out in the security waiting line at Heathrow.
Oh.
About working in cancer today, on any of the complex cancers you have to collaborate. And so I thought it was a great sign, but I think what we're seeing is, and this was a deal between people who were scientists. The scientists are driving us, as they should, to say we've got to figure this out and we have to combine therapies. So I thought it was a great sign.
You know, much of what you've been talking about is treating diseases.
Yeah.
And I think one of the hopes that understanding the genetic code at least provides is the notion of prevention. About it before we get to the stages with all these complications. And obviously the statins and cardiovascular disease are the first major preventative drug. But there's hints with things like prostate cancer, a simple drug that if we know you have an increased genetic susceptibility to prostate cancer, it's estimated it could lower prostate cancer rates by about a third in this country. It's not something you'd give as broadly as statins. Predicting susceptibility and then using new preventative measures, we can do something about lowering the cost of health care, improving life outcomes by preventing diseases before they occur.
Yeah. Well, maybe I can call on Peter Carroll to make a few comments on that topic, because part of his program involves issues related to prevention, but also he's done a lot of work on overdiagnosis and the consequences of detecting people's PSA levels which don't have a meaning. So, Peter, would you? As long as enough.
I enjoyed the comments, and I think they're especially relevant to a cancer like prostate cancer, which is really a spectrum of disease. You know, we've become so efficient at detecting prostate cancer that we detect many cancers which are so small and slow growing they'll never be at any risk for the host. And one of the problems in this country, if you're we could identify non-progressive prostate cancer with a test and not treat patients would be a huge benefit in certainly the diseases that we look at. And fortunately here at UCSF, we have the largest cohort of men on active surveillance in actually North America. The comment I would have, of course, is you will have to change the reimbursement incentives in this country to reward people for not treating or treating appropriately rather than just treating. So I think in healthcare, again, to incentivize for appropriate treatment, even when that means non-treatment. It's interesting you mentioned about prostate cancer and risk, because we refined the guidelines for prostate cancer detection this year with much controversy because we lowered the rate of screening to identify men who are at risk, who perhaps don't have the disease, so they can be counseled for chemoprevention strategies. And we do have 2 agents that do reduce the risk of talking about biology, but here at UCSF we have a whole group of people looking at other things that may predict for cancer outcomes, and that's the society in which we live. So we talk about biology, but you could have the perfect biology but the worst insurance and the worst access, and you're not going to get that drug. And so I think there's a whole group of people working on that aspect of cancer care, this issue of insurance, access, and appropriateness of care.
Okay, thanks a lot, Peter. I want to say something about early detection, which has been another sort of hope for the future, that thinking that we can detect cancer early, we'll have better outcomes and so on. It really hasn't worked out as well as one would have liked, I would say. Wouldn't you agree? Yeah. Is that because the earlier cancers are, the more they're like normal cells and therefore the less to get a grip on, or is it just we're not doing things correctly?
Well, I think early detection is a tough field, and I don't think you can put all cancers together. I think it depends on the cancer, and most importantly, it depends on what you similar to what Peter was just saying about prostate cancer, but in ovary cancer, in terms of overtreatment. A really nice study was presented from the UK where women who had ovarian cancer were put into complete remission with their first course of chemotherapy. So they had a really good outcome with their first course of chemotherapy, but they're at enormous risk for relapse. So today, those patients are followed with CA-125, a diagnostic test that makes you more nervous that the cancer's coming back.
Right.
And what the docs in the UK did is they said, gee, half the patients will treat them right away with they're clinically sick. The patients did the same, regardless of the delayed versus right-away therapy, and the quality of life was worse in the patients who were getting treated right away, which was very disappointing. And I don't think CA-125 is a bad test. I think our second-line therapy is so poor that doesn't make a big enough difference. So I don't think early detection is good or bad. I think early detection is only as good as something that we're correcting when we actually treat, when we detect.
Right.
Yeah. In fact, like I found a melanoma on my back, and knowing what it looked like early on, I was able just to have it removed.
To have surgery.
With surgery before it was able to penetrate very deeply. So early detection with some types of cancers can totally eliminate other effects.
Did your genome reveal any risk for melanoma?
It didn't show anything obvious, no. Maybe there's a sun-liking gene, though.
Yeah.
Okay, I just want to... we'll come back to that later on. Yeah, so having read your book, which I really enjoyed, you show a lot of anecdotes in your book where you identify gene variants which account for some of your behavior patterns, such as your ability to swim a long distance or your attention deficit problem and other issues. It didn't seem like you discovered anything that was actually actionable in terms of things you'd change your life based on. You say, damn, I better do something differently. Do you think that's going to be the way it's going to play out as we get more and more of these things, or will it be real decision-making information which will change change the way that you do things?
I think the limitation is how little we know about how to read the genetic code. So having 1 or 2 copies of the human genome doesn't give us that new knowledge. It gives us the basis for getting that knowledge.
Mm-hmm.
So in 10 years, if we have these databases with tens of thousands to tens of millions of genomes, and we'll tell a whole lot from our genome. Not everything will be actionable. I think if people are interested in this, there's a couple of private companies, 23andMe and Navigenics. I think you're an investor in Navigenics. That they can do these quick and relatively cheap surveys, but they start to teach you on their websites about the statistical probabilities of things. So I think I call them companies that help the democratization of genomics instead of just being run out of the government. It's a very complex thing for...
Right, well, you can understand that, but most people can't.
Well, but all of us have to if we're going to be able to, as physicians, deal with patients, and for individuals to teach their physicians how to deal with things. So it's...
Right. Well, how are we going to do that? How are we going to educate the population what it means to be at 1.2-fold risk for a disease? Or, I mean, it's hard enough for many people to understand what it means to be BRCA1 mutant in our population. We have a very active cancer risk program, and the council has spent a lot of time factors. How are we going to deal with that?
I think the culture will change as this information starts to permeate out there. I mean, it's only been 8 years since our first draft of the human genome. Trying to get a large number of them, if every genome cost $100 million, we wouldn't get very far.
Right.
So we've been waiting for all this new technology to change it. I think there's an increasing population. Get genomic surveys and some basic information. People are doing a lot of family lineage studies as they understand the Y chromosome linkage to their past or the mitochondrial genome to their maternal past. I think as it becomes part of the public through, in fact, some of these websites, patients will be educating their physicians in this area, probably not the other way around.
Right. But it'll be the more educated, savvy people will benefit way before the general population, I would guess. Types tested by 23andMe or in one of those organizations? John. Well, John is co-director of our cancer genetics program, so if he can't understand the statistics, nobody can. So what did you learn, John? Come. And did you pay for it also?
Free sample.
So there were 3 types of information that I probably learned about. The first was actionable things, and unlike Craig, I am a slow metabolizer, and in fact this could impact my prescription, say for Coumadin, something like that, because it looks like I have genetic variants that suggest I need a lower dose for that drug. So that's actually valuable information. Some of the other information was kind of... I apparently am not going to be a power weightlifter in the Olympics because I don't have the right genetic variant.
What a surprise.
I just lost my bet.
The third type of information is a little bit troubling. So I have found that I actually have about a 20% increased risk of prostate cancer based on my genetic test. But this actually wasn't, it didn't change anything at all about what I would do. It wasn't really an actionable item. And I'm not so sure that that it really matters to me. But I think for the general population, it could be very troubling. And as Craig pointed out, that you're going to have people going into their physician's office saying, hey, I have an increased risk of prostate cancer. I need to be screened more often. which means I'm more likely to have over-detection and over-treatment, which I don't think is going to really help the cost of our healthcare system in the near term, because there's a good chance that we're going to have people demanding more tests and more things that are going to end up being expensive without having much pay. Actionable, and that will come with more information about the genetic code.
How about that Atlas site you told me about?
Yeah, so for the same gene variant that tells whether you should be a power weightlifter or an endurance athlete, there's a company out of Colorado called Atlas Genetics, which is offering to genotype you or genotype your children to determine what kinds of sports you should push them into. Really. Genotype, and you should be a better athlete because you've got this genotype.
That's great. That wasn't one of your companies, was it, Brook?
No.
No. And actually, the scientist who cloned this gene, his response was, there's a really cheap way to figure this out. You line up the kids and you say, go.
Excellent.
And you look for correlation.
Yeah. Great. Well, we do have one question from the crowd, which Sue's going to answer, and then I'll ask Brook to wrap up.
Let's see, I'll read the question. What can biotech learn from academia? How do they best work together, and maybe an example? I find it really hard to overgeneralize. I'll tell you what I really loved about the experience I had in the last 14 years working in biotech. And I think this happens in academia as well, though, so I'm not sure the contrast is fair. What I loved is the great sense of urgency, and that in a publicly traded company, you were accountable to shareholders. Some people, if there's people who it's a little like when they come and review your grant, I guess. You know, the day of reckoning is there. And I just found that sense of urgency and a sense of accountability to be really tremendous. Particularly as a person who works in R&D, I had often heard feedback from colleagues in R&D, well, you know, it's science. I can't make sure it's going to happen or make something happen for patients. And I would think, well, gee, if we're investing the company's money, and I would say in academia, someone's money, you know, and the sense of accountability that every penny is spent wisely, that's probably what I liked about the business aspect the most, is that all of that for me drove things in the right direction to say, boy, I better hurry. What I love in academia is just the opportunity to be so close to patients. I think that's what I missed most in biotech, and the reality of patients waiting and patients needing what we're doing right now, that sense of urgency that the patients are there is so much more real and present.
Brook, would you like to say a few farewell words?
Well, Frank asked if I would say something at the end. I was thinking about, well, what could I say at the end other than how great UCSF is to bring all of this together. And then I was thinking this morning, what's a good aspiration for this center and your activity and what's going to go on here? What I think the dream is, right? And I'm going to try to do this in one breath. So this is the dream therapeutic that can solve all the problems that we've talked about. A biomarker-enabled, patient-specific, relevant, deep sequence-derived, crystallography confirmed, nanotechnology encapsulated, time-release, phosphorylated, pathway-clever, restoring, clinically validated, FDA approved, low cost, fully reimbursed cancer cell death juice.
Definitely. Right? We can do it, damn it.
Good job.
Well, thanks again for the panelists. You've been great. I really enjoyed it so much. Thank you so much. Yeah, one more time. Thank you. Press for 10 to 15 minutes or so. So if you still have questions for them, they will be hopefully up there getting refreshments. I know I will be in about